Get started. All right, so hi everybody, my name is Maddie Haley. I am the AIRP project manager, and I want to welcome you all to the webinar series for the Autism Intervention Research Network on Physical Health, the AIRP. Thank you all for joining us today. Because of the number of participants, your audio will be muted throughout the call, but you can submit questions at any point during the presentation via the chat box on the webinar console or via the Q&A function on your webinar console. This entire webinar is being recorded and will be available on our AIRP website, which I will put in the chat right now. And there will also be a short evaluation survey at the close of this webinar, which we invite you to provide feedback for on this webinar and also to provide suggestions for future webinars. So let's go ahead and get started. We first want to acknowledge the Health Resources and Services Administration as the funding source for the AIRP, and it is my honor to introduce our speakers for today. Dr. Lindsay Shea, who is the Director of the Policy and Analytics Center at the A.J. Drexel Autism Institute and our AIRP Health Systems and Services Research Node Leader. And if you have been attending our webinars frequently, she was also at she also presented at our November webinar. And Dr. Stacy Nonnemacher, the Clinical Director of the Bureau of Support for Autism and Special Populations at the Pennsylvania Department of Human Services. So please join me in welcoming Dr. Shea and Dr. Nonnemacher.
Thank you, Maddie. I appreciate it. We're here today to talk about one of my favorite topics, which is Medicaid. This is the public health insurance program in the United States, and I'm very pleased that my colleague, Dr. Nonnemacher, is here with me as well. It's been truly sort of the thrill of a career to get to learn more about Medicaid and see it through Dr. Nonnemacher's eyes. And so today we're going to be talking with you about some of the research that I've been doing in the national claims data, and then also drilled down on state innovation in Medicaid. And that is certainly where Dr. Nonnemacher sits at the helm in terms of thinking about ways to move forward the Medicaid program to serve autistic individuals. So to make sure we're all on the same page and to get a lay of the land, there are multiple ways that individuals can get insurance, health insurance specifically, in the United States. We know that there are many individuals, so 216 million Americans receive health insurance through private health insurance, and that's typically gained through employment. So if you have a job, your employer may pay all or a portion of your insurance plan. Or if you gain insurance through the Affordable Care Act marketplaces, that also counts as private health insurance. There are about 28 million Americans who have no health insurance or are paying out of pocket for their health insurance. There are 12 million Americans who are served by TRICARE or the Veterans Administration, which is for our fellow individuals who are serving in the armed forces. Medicare is different from Medicaid, and it's hard because they have very similar sounding names. Medicare is an entitlement program that Americans receive when they turn age 65 or before age 65 if you have certain health conditions. Medicare is different also because it's administered by the federal government and versus Medicaid, which is a partnership between states and the federal government. And there are about 60 million Americans who have insurance through Medicare. Medicaid, which is often thought of alongside the Children's Health Insurance Program, which is run by states, or CHIP, is a federal state partnership in that the federal government has a certain set of rules that states must comply with or meet a bare minimum standard set by the federal government. And then within that partnership, states have flexibility to think about ways that they need to shape policies, programs within their state to meet the needs of unique populations, emerging populations, or in general, the individuals who are living in their state and need healthcare coverage. There are about 73 million Americans who have coverage through Medicaid or CHIP programs in states, and we often see the CHIP program paired with Medicaid data anytime you're seeing Medicaid data. So as we move forward, Medicaid is a program that's available all across the lifespan for autistic individuals, depending on meeting certain eligibility criteria. And we're going to talk more about what that means and also how that has taken shape in Pennsylvania versus Medicare, which is a program for older adults age 65 or over, or with certain health conditions before age 65. And today we'll be focusing on Medicaid. Medicaid has all sorts of names. So much of this depends on how states have branded their Medicaid programs. So for example, my colleagues who are here today from California, often Medicaid in California is called Medi-Cal. In Tennessee, TennCare, Delaware, DMAP, Maine Care, Mass Health, Sooner Care in Oklahoma. So even though we're trying to talk about a shared topic, which is Medicaid, it may actually have a different name depending on where you live or what your state has decided to call the programs that are within the state program Medicaid portfolio. So Medicaid eligibility, we can broadly think of, and in general, when we're using big national data of people who are enrolled in Medicaid, of those 73 million Americans, we could think of how people gain access to Medicaid in three broad groups. So the first is disability. If an individual has a diagnosis, in this case, and relevant to our shared network of activities, an autism diagnosis. And then there are also other criteria. So for example, level of care requirements, where an individual must have certain service or support needs in certain areas to a certain degree in order to enroll in state Medicaid programs, in addition to their diagnosis. Individuals can also qualify for Medicaid through poverty. So an individual may meet the requirements for Medicaid because their income is at a certain level. And we know that the Affordable Care Act standardized the requirements because states had highly variable poverty requirements for individuals to enroll through this category. And the Affordable Care Act really sort of raised the baseline in terms of how individuals and states determine who might meet these criteria. And then there's a third group of Medicaid eligibility criteria or programs that are offered through states that are based on state decisions that are approved by the federal government that meet the needs of the populations within those states. So for example, there are programs for individuals with HIV/AIDS. If you are pregnant, you're automatically eligible for Medicaid. And there are other very local based programs, one of which is based in Pennsylvania that Dr. Nonnemacher will cover later today as well. So when we look at who's covered by Medicaid and we look at those 73 million Americans, we see that there are mostly children, 43%, about a third are adults, 12% are individuals who are labeled in this data source from the Center on Budget and Policy Priorities as blind or disabled, and then 8% being older adults. But when we look at spending in Medicaid programs, so the resources within the Medicaid program and their allocation, we see that that blind and disabled group is actually a third of the resources that are spent in Medicaid as compared to that slightly bigger portion for adults and a smaller portion for children, despite the fact that they make up more of the individuals enrolled in Medicaid. And this makes it really important to pay attention to how Medicaid is structured. How do we think about ways to shape the policies and programs and support people like Dr. Nonnemacher who are thinking about state programs and ways to best serve populations with these limited resources? So in a recent publication that our team released using some of the newer Medicaid data nationally, we see that the number of individuals on the autism spectrum served within Medicaid in the nation has been increasing steadily. So we have newer data and we'll be updating this figure soon, but here you can see across these adult age groups, so this is focused on individuals 18 and older, so we're really looking at adults. The biggest growth is actually among transition age autistic individuals, ages 18 to 24. And that means that those individuals, because we know in most cases autism is a lifespan diagnosis, that those individuals are going to, as they age, contribute to those lines in the lower component of this figure and increase it. So we know that this group is overall growing. It's growing the most quickly among younger adults, but that group is also going to age into older adulthood. And how do we think about ways to support what they may need? Another way to look at this is by year. And so when we take the raw data and put it on a line and see how these ages are moving forward, we've heard about a tsunami, we've heard about a tidal wave, and there may be a way that I've certainly heard critiques of that because it suggests that there's a time at which it will wane or at which it will no longer be present. And the reality is that the individuals who we see here in these differently colored lines are going to continue to age, and that increase will move to the right, and that there are more younger individuals moving along behind them. This also corresponds with the CDC's latest estimates, which indicated an increase in the prevalence of autism in their sites across 11 states to monitor surveillance of autism in their populations. So we know that Medicaid is an important payer for services for autistic individuals for a few additional reasons. First, many states have taken care to generate new programs for children and adolescents on the autism spectrum. There are waivers, which are specifically designated programs for children. And we know that those waivers are intended to help support, especially when we see that CDC headline of 8-year-olds, that's the population that the CDC focuses on, that those Medicaid waivers are meant to help those children gain access to services and supports that they're likely to need. We also know that individuals in the autism spectrum are likely to have relatively lower employment outcomes than even other peers with diagnoses. And so when we think about how individuals get insurance, health insurance outside of private health insurance, which you gain through your employer, per our previous slide, Medicaid becomes among the only options that are available to people across the lifespan. So Medicaid is important not only for autistic individuals, but for autistic individuals of all ages. So what does Medicaid cover? There are a set here of mandatory benefits that the Centers for Medicare and Medicaid Services, which is the federal entity that oversees Medicaid programs, denotes. And they include inpatient services, outpatient services. There's an entire bucket of early and periodic screening, diagnostic and treatment services, nursing services, physician services, laboratory services, family planning services. There's a constellation here of medical services that are linked to physical health and health outcomes all across the lifespan. Optional benefits that states may choose to include for their Medicaid enrolled populations are also a wide array of both medical options, prescription drugs, thinking about dentures, prosthetics, eyeglasses, but also pivoting into the services that we see at the front line of options for autistic individuals, including in childhood, physical therapy, occupational therapy, speech therapy, and also thinking about home and community-based services. So services that help people think about where they want to live in their community, how do they stay in their community, how do they engage in the community around them. And that's a place that Pennsylvania has been exceptionally strategic in thinking about both programs and then also the services within those programs that can link up to the needs that individuals, autistic individuals, report that they prefer to access as they age. When we think about these types of services, home and community-based services, long-term services and supports, these are services that are meant to keep individuals out of institutions, right? So as we look at trends in spending patterns and enrollment in types of Medicaid programs, we can see the green line has decreased and in the 2000s became lower than the gray line, which are services that are delivered in communities. So what we really see here is the crossover of a majority institutionally based services where individuals were served in inpatient settings versus a switch to more outpatient community-based services. In 2016, we know that Medicaid spent $94 billion on home and community-based services to enrolled populations. So this is really an important way for us to think about Medicaid in terms of physical health. How do home and community-based services consider and support meeting the health outcomes and needs of individuals on the autism spectrum? So home and community-based services can include many different kinds of options. And Dr. Nonnemacher will be talking more about home and community-based services and how they look in Pennsylvania. Across the nation, there are different ways that states think about providing home and community-based services. And as you look at these examples and how they're often delivered through Medicaid waivers, it's also important to think, what are the differences in how these services might be used across the lifespan? How do we think about the services that might be needed in childhood, services that might be needed in adolescence, and services that might be needed into adulthood? So as we think about job coaching and how that may emerge during the transition to adulthood and during adolescence to help prepare for that adult period, where a job is exceptionally important in thinking about ways people prefer to be in their communities, thinking about supports for everyday activities and lives, getting dressed, taking a shower, eating. These are all services that directly link to physical health outcomes because they keep people in their homes, in their communities, and also help them meet the needs that they and we all have every day to take care of ourselves. One way that we've thought about using the national data to consider service needs across the lifespan is to think about how in the last 22 years, as we've seen the CDC's ADAM network continue to document the increasing prevalence of autism in the United States, how have states shifted their approach? We talked about how Medicaid is a partnership between the federal government and states. And so in what ways have states used the latitude on their end of that partnership to create new options specific to autism to allow for this increasing prevalence and for individuals to receive services? And so what you see on the left of this figure is where states started. In 2004, 3 states had autism-specific waivers. 30 states had waivers that served autism and intellectual disability. 11 states had waivers that served only intellectual disability, and 7 states had neither of those types of waivers. And we do see changes, the middle part of this figure where you see the tendrils moving from the light gray to the dark gray to the black. We can see that states increased the number of autism-specific waivers that existed in hopes of serving this population, in hopes of addressing the needs of this population where we see an increasing prevalence. We also mapped this out by state. And so using color coding, where Black states added autism-specific waivers, the darker gray states added a waiver that serves both individuals with autism and intellectual disability, and then the light gray states where there's no change. You can see how these states activated differently in order to try and meet the needs of this group. Of note, there are 3 states that do not have the type of waiver, 1915C waiver, that we thought about during this study. Vermont, Rhode Island, and Arizona use a different type of mechanism to serve individuals. So as we think about the eligibility criteria for Medicaid, we can get a little more specific, right? So we mentioned that the Affordable Care Act has a requirement for poverty to be at 133% of the federal poverty level. And that equates to $16,971 for a single person in a year of income that may not be exceeded to meet that poverty requirement. We also know that the disability category requires some specific components that individuals in certain groups, like individuals who are in foster care or pregnancy, are able to also meet criteria for Medicaid across states. And when we've looked at the national data and sought to identify how people enroll in Medicaid, this is a table from a publication a few years ago using older data. So this data is from earlier years, 2000 to 2005. And we found that among autistic youth who are aging into adulthood, more than 1 in 4 lost eligibility for Medicaid. They disenrolled. So they no longer had access to that list of services that we saw earlier that ranged from medical services, those required by the federal government, as well as those that states allow, and also to those home and community-based services that really help to think about where individuals want to be and how they want to spend their time. Among those 1 in 4 who disenrolled, about 1 in 3 were able to get back on to Medicaid. And people who disenrolled and did not re-enroll in Medicaid were more likely to potentially face other aspects of health disparities. So for example, individuals who are Black or Latinx were more likely to lose access to Medicaid as they aged into adulthood. And it's really important to understand where these gaps are happening so that we can try and identify strategies to address them and retain access to Medicaid among individuals who are more likely to need it. This is another recent paper using newer data. This is 2008 to 2012. And we sought to examine when exactly, at what ages, did autistic individuals aging from adolescence into adulthood lose that access to Medicaid. And here we see spikes. We see literal points at 19, as well as age 21, where individuals were more likely to enroll from Medicaid. And there may be something important here about the transition into adulthood, about people aging and getting older, about how states operate their programs. There are transitions during the aging into adulthood where individuals are assessed not only as a member of a family, but then assessed as their own family unit. And these changes could yield points of increased risk for individuals to lose access to Medicaid. So this is, again, an important way for us to think about the autism group, which is the most at risk overall, as well as during these 2 age groups in this study, and identify strategies to help keep them enrolled and engaged in the services should they need them. Another feature of Medicaid is to think about waiting lists. So there are many states where there are not enough resources to enroll individuals who may qualify for services, and they put into place waiting lists of individuals who are typically either known to be eligible for Medicaid or would be assessed for Medicaid eligibility prior to enrolling, and they are waiting per the name waiting list. Number of individuals nationally who have been counted, it has been increasing. To date, to 2017, last known count, there were more than 700,000 individuals on waiting lists for home and community-based services through Medicaid. Of note, there are also some states, including some very large states, that do not have waiting lists. They only enroll people when there are resources available to expand their Medicaid programs. And so these waiting list numbers are startlingly large, but also likely do not include many individuals who might also be waiting for services but simply have not yet been counted. So when we think about who's on these waiting lists, we can see that the largest proportion are individuals with intellectual or developmental disabilities. So more than 470,000, or 2/3 of individuals on the waiting lists of that last count in 2017 were waiting. So we did a study a few years ago in partnership with some autistic individuals who responded to a needs assessment survey in Pennsylvania. And we found that there were a variety of services that individuals on these waiting lists said that they needed. There were functional skill services, employment services, mental and behavioral health services, and more than a quarter, indicated that they needed case management services. In this article, we also saw reports of needed physical health services, and we saw differences in risk for who needed these services across other known groups who are experiencing health disparities, which indicates that these areas of thinking about waiting lists are needed. So we've started to look at co-occurring diagnoses physical health conditions specifically among autistic individuals enrolled in Medicaid. And this panel presentation, you can see on the top, there are a set of conditions for which autistic adults are less likely, so they're at lower risk for having a co-occurring condition. And then there are a set of conditions on the bottom where we see higher risk of these conditions. So we see elevated risk for epilepsy, Parkinson's, pituitary gland, and other symptoms concerning nutrition metabolism, all in places of increased risk for autistic adults in comparison to other groups, so individuals who do not have autism. This graph is complicated. We won't walk through this graph, although I'll invite you to read the paper should you be interested. Another important element of this study was that the lead author, Dr. Whitney Schott, was able to identify that there are racial and ethnic disparities related to risk for these co-occurring physical health conditions. So when we look across the different color dots, individuals who have increased risk of a variety of conditions present new starting points for how we can consider how these diagnoses emerge, when they emerge, how might we need to shift or change, considering needs within Medicaid programs to meet these physical health conditions. And these are conditions, many of which are either could be life-threatening, so diabetes, as well as conditions that are manageable when services are delivered and provided to these individuals. So this presents another starting point for us to understand where and how Medicaid is functioning and where it may need to continue to grow or evolve to meet the needs of these groups. Other research not using the same data has found that there are high rates of prescription drug use and polypharmacy among autistic adults all across the US. We've also used these data to begin to look at COVID-19 risk. And so this paper identified that autistic Medicaid enrolled adults are at elevated risk for COVID due to a variety of factors. This figure, which was included in the paper and has these three maps across the US, indicates how beneficial it can be to study these issues within the Medicaid system for several reasons. First, we have very large groups. So we can see that many individuals who are enrolled, and that allows us to do comparisons like those that we just displayed. It also allows us to take these findings and think about how can they be valuable to Medicaid today? How can we use these data to try and help support the system and thinking about change or where things are needed? And how can we take this research and make it as meaningful as possible? And with that, in terms of making things as meaningful as possible, I'm going to hand the presentation over to Dr. Stacy Nonnemacher to talk a bit about our great state of Pennsylvania and Medicaid programs.
Thank you so much, Lindsay. I am so thrilled to be here to talk more as Lindsay introduced the work that we're doing here in Pennsylvania. We're so lucky to have a brilliant mind like Dr. Shea's here in Pennsylvania to be helping us guide the decisions that we make in the administration of the adult programs that we oversee, which I'll talk a lot about in the next few slides. First, just by way of a bit of context, it's helpful to know, where we live within our Pennsylvania system. So we're part of the government system that can sometimes be very complicated, and we made it look less like a spider web here, but it feels very spider webby as we go about doing our work. But we do live within the Department of Human Services as the Office of Developmental Programs with some of our other colleagues and partners, the Office of Mental Health, Office of Long-Term Living, Office of Children, Youth, and Families. If we drill down a little bit, next slide, please. In the Office of Developmental Programs, there really are two bureaus who we are overseeing, specific programs in Pennsylvania. Bureau of Community Supports, a very long-standing bureau that oversees historic intellectual disability waivers. And then our bureau was established around 2006. Really established at the urging from stakeholders in Pennsylvania And in the beginning, prior to bringing up these two adult programs, we were really established to consult to some of those other offices I mentioned who were serving people with autism, whether they signed up or not, right? They were serving kids with autism in behavioral health, in foster care. So we spent a lot of time early on consulting with those offices. We still continue to do that to this day. But really where we put our effort and our vision was really to design these adult autism programs, which I'll focus on, and which we were so fortunate enough to build from the ground up. So we built these two programs, the Adult Autism Waiver and the Adult Community Autism Program, and had them approved around 2008, 2009. But an interesting thing happened as part of our evolution that I think really is worth mentioning as I was listening to Lindsay talk about the national landscape. From 2008, 2009 until 2017, here in Pennsylvania, for adults with autism, the primary place that they were receiving services was either in the mental health system if they had a mental health diagnosis, or in the two adult autism programs that we had designed. If they did not have an ID diagnosis, they were not receiving services in those other three: consolidated community living or person family directed support waiver. In 2017, we did expand the eligibility criteria in those three waivers to include autism without ID. So the reason why I bring this up, the reason why I think it's important to this conversation is back to what Lindsay said about eligibility. So this is one place where we really had to think about what determines the federal rule for eligibility. What determines specifically what substantial functional limitation looks like, which is part of that rule. And unlike intellectual disabilities, we know with autism that IQ does not predict functioning, right? So we had to modify within our own existing processes, those ID processes, to account for this. So, definitely some growing pains there in our state, but again, more opportunities as of 2017. So prior to 2017, again, very limited opportunities for adult with autism in Pennsylvania. We had programs, right? But we only had certain capacity within the programs. So in 2017, when we opened up all these other programs, again, with some growing pains worked in there, we were able to expand the opportunities for individuals with autism. Next slide. Great. So, before I jump into specifically what we have done in the two adult programs, in the office, we have a medical director who has been wonderful at initiating programs across the state, office-wide, looking at some physical health needs that we have here in the state. And I just want to share a few of those with you. The first one is our Fatal 4 initiative. And these are, the health issues of aspiration, dehydration, constipation, and seizures. This is predicated on the concept that in community settings, the more that direct support professionals know about these 4 medical conditions, and the more that they're familiar with these medical conditions, the more proactive they can be. And so we know that if people can identify proactively when somebody's aspirating, somebody's dehydrating, we can treat them earlier. Since we started this large capacity building effort around the Fatal 4 across Pennsylvania, we have seen a decrease in incidence across those 4 areas. We also have what's called the health risk screening tool that's administered for individuals who are receiving residential services in Pennsylvania. For those of you who don't know, the HRSA is a screening tool that really is a risk management tool, if you will. it looks at and it detects health destabilization. So again, more of a screening tool, more of a proactive way that we can keep our finger on the pulse in terms of making some real-time care decisions specific to physical health. We also have within our regional offices in Pennsylvania, nursing staff. And these nursing staff are really crucial to some of the things that we are seeing that cause red flags in our programs specific to physical health, to medical needs. So if we're identifying that a participant is struggling, whether it's through the HRST or other mechanisms that we have in Pennsylvania, we're able to bring in qualified nursing staff into the conversation to help us have these conversations about the quality of supports that somebody is receiving, what providers may need to support someone better around their physical health needs. And our nursing staff really will go above and beyond, even if we're looking for them to do something like an on-site inspection to ensure that the home that the person is living in is supportive of their physical health needs, or to provide any additional support that, again, the provider, the family, or the individual, if living independently, may need. And similarly, our office contracts with what we call healthcare quality units. We have 8 healthcare quality units in Pennsylvania, and their primary function is at the request of providers, families, or individuals. They provide education and consultation specific to medical and physical health needs. So they do diabetes training. They will issue health alerts. So they would issue like a flu health alert, heat advisory health alert, and really is the arm of ODP, all things physical health, and they're overseen by our medical director in Pennsylvania. So I want to talk more specifically now about the 2 adult autism programs I keep mentioning and Lindsay was mentioning. As I said, both were approved by the Centers for Medicaid and Medicare Services around 2008, 2009. And at the time that again, we were fortunate to design this from the ground up, what we knew about supporting this population, what we would do differently for those of us, including myself, who had spent a lifetime supporting individuals in our ID programs. We also knew that there was a paucity of research in supporting adults with autism. We're certainly getting better as a field, as some of you may know, but we definitely have a long way to go. At the inception of our programs, we were borrowing what we knew, whether it was in the KID system, or whether it was those things that could be generalized that we knew were working in the ID systems or the mental health systems. So we were changing the wheels of the bus as it was moving, if you will. So the Adult Community Autism Program, which is the first one I'll talk about, is a 1915A managed care program. And this program is available to Pennsylvanians 21 and over, and currently only available in 4 counties. So because it was new to us as a managed care program, new nationally as an adult autism program, and again, given the paucity of experienced programs out there for us to learn from, we really want to start within these 4 counties. As Lindsay was going through the list of what Medicaid will cover, both primary and optional, I couldn't help but think about the array of services that we decided here in Pennsylvania to include in the Acap program. These services directly align as well with the needs assessment data that Lindsay highlighted earlier. So you're going to see the behavioral support pieces, which is captured under specialized skill development. You're going to see some of the employment pieces. And, a shameless pitch here that Acap has some of the highest employment rates in Pennsylvania in terms of employment of our participants in the program. So we do put a really strong focus on all things home and community based. However, let's see if you could go to the next slide. There really is a unique marriage, if you will, of the home and community-based services and the physical health in the Acap model. Acap is the participant's health insurance, and the provider that we have chosen to oversee the program was primarily or historically a home and community-based provider. So they learned a lot about being a managed care provider and navigating both the physical health services with the home and community-based services. So having that one provider oversee everything, whether they're providing those services directly, and they provide most of the home and community-based services directly, or whether they're managing their provider network, who is providing those services that this provider is, the managed care provider is not providing directly. There really is a strong need then in a model like this to have very good case management, supports coordination to assist with scheduling and maintaining medical appointments. And anecdotally, we have heard from families and individuals who are living independently, you know, what a huge burden that's lifted off of their shoulders. I know in our daily lives, right, we're constantly navigating setting up appointments and keeping appointments and managing appointments. And so for some families and individuals who may have been struggling prior to coming into the program, this really was a big relief for them to have someone who was overseeing and navigating that for them. The one thing, you know, when I have conversations, both internal to Pennsylvania and external, that I like to highlight is, you know, really in a model like this, one of the primary benefits of a model like this is really the strong coordination, which accounts for that holistic, sometimes elusive supports that we talk about in HCBS. And really truly can be done here in Acap. One of the things that I think is very key to the supports that people are receiving, adults with autism, is to be able to be responsive, to be able to be timely in responding to what that participant needs and not have to go through layers as happens in some other waiver programs in order to get services changed, supports changed, amounts changed, authorizations changed. This can happen easily. It can happen on a moment's notice within this program because, again, it's one provider who's overseeing everything. The Director of Health Services that's part of this program has been a valuable addition to the provider administration and was identified as a need by the provider, not us as the administrative entity. And they started including that as an executive position within this model. And, you know, he has been crucial to all things, you know, whether there's providers or staff who need education on medical conditions that some participants may have, may need to navigate conversations with doctors or pharmacy. As a registered nurse, he's able to have those conversations. But another piece that Lindsay talked about, polypharmacy was a significant concern for us when we were building these programs. We knew that oftentimes individuals with autism who were misunderstood, who may have had language, but was really struggling to communicate, who was resorting to behavior to get their needs met, were often medicated and heavily medicated. So at the outset of this program, we wrote into that agreement that the provider needed to have oversight of pharmacological and monitor that ongoing. So the Director of Health Services is really integral to us keeping our finger on the pulse with the participants in this program. The other pieces really just that are important to this coordination within this program is that those medical practitioners, whether it's the family doctor or the PCP, or if it's a specialty physician, they're really working very closely, whether it's with the Director of Health Services or the supports coordinator, so that we're able to better coordinate our goals, our treatments, our progress. Everybody, is bound by really one vision, one plan in this program. And if the physician is part of the network of providers, they're contracted to be part of the team. Now, in fee-for-service or a traditional 1915C waiver model, you're going to have lots of different providers and lots of different physicians outside of the waiver that sometimes gets frankly, herding cats, right? And trying to get them together and stay consistent with treatment, with staying on the same page with goals can sometimes get a little cumbersome. Like I said, there's community supports, that's at the hallmark of this program as well, wanting to get folks out in the community, wanting to get folks employed if that is their desire. And what we knew, and one of the pieces that we borrowed from what we knew worked well with children, transition age youth, is using a service like behavioral support services to guide, using techniques like applied behavior analysis to help build skills, to help shape behavior, to help people to really be able to benefit from fully and meaningfully being engaged in the community. So, I always like to, and Lindsay and I do a lot of work together, but I like to highlight, the cases from our programs. And in this particular case, we have a gentleman who has been with the program for almost a decade. And prior to coming to our program, he had earned a bachelor's degree in electrical engineering. And he had graduated from college, but he had experienced some significant physical and mental health deterioration and ended up in a state hospital for 5 years. Luckily, he became known to us, and upon discharge, he enrolled in Acap, where he returned home. Acap provided services, and we're assisting his elderly parents with ongoing coordination of his medical care. From that, again, the physical and the mental health. He was losing skills, mobility, cognitive functioning. He saw a lot of specialists. Acap was helpful to the parents to help navigate that. Unfortunately, what happened, there was an increase in physical aggression. The parents were living in fear. And because the provider was able to see this early on, they were able to pivot and plan for a transition to residential services. So they could support him in a home of his own with behavioral specialist services, with residential habilitation services, with skill building services, and focusing really on his goals being physical therapy and activity to minimize or prevent further decline in mobility, working on communication instead of engaging in the physical aggression and property destruction, working to identify his own physical health needs when he was in pain, because sometimes the hypothesis was that he was engaging in this physical aggression and property destruction because of that. And the Director of Health Services has been crucial to all of this and bringing the staff along so that they're able to more appropriately support him. That's just an example of Acap, and I'll switch gears a little bit now and talk a little bit about the adult autism waiver, which is a 1915C waiver. And this waiver is considered a fee-for-service waiver. Very similar services you'll notice with Acap, pretty much the same home and community-based services, does not have all of the bells and whistles of the physical health services. But I do want to talk a little bit about the unique services that can bolster the physical health for individuals. So we have what's called the Specialized Skill Development Suite. And under there's 3 services. Lindsay, if you go to the next slide, please. Thanks. And we find these to be crucial services because they span really any assessed need that we identify with an individual. So if we're assessing that there is a need around physical health, we can design plans to teach skills. We can design plans to address behaviors that are interfering with optimal functioning. And then we also have, outside of the systematic skill building and behavioral support services, the community support service, where those folks are implementing the plans that the clinical folks have developed to build the skills and to address behaviors interfering with optimal functioning. I think it's easier to sort of get a flavor of what that looks like with some examples. So in terms of systematic skill building, we had a gentleman come in through Adult Protective Services. He hadn't been to a doctor in years. He was overweight, had high blood pressure. The team really worked with him on making healthy decisions, as well as identifying and choosing healthy meal choices and snacks. And they encouraged him to try new seasonings aside from salt, which he always used to flavor his food. And this all sounds rather simple, but really integral to his overall physical health. The team also worked with him on scheduling and attending appointments because this was something that really he struggled with. And this led to him getting proper medical care to meet many of his untreated medical needs. Certainly these services work very closely with one another. And another example, we see quite a few participants in our programs who have hoarding behaviors. And we have one gentleman who, direct implication on his physical health. He really was struggling with chronic respiratory issues and asthma. And the behavioral specialist built a strategic behavioral support plan to tackle some of the cleaning. For example, so it wasn't so overwhelming for this participant, but they would start with the most frequently accessed areas. Then they moved to places where guests would congregate because he wanted to be a host, but he knew that, the state of his home was not a bit, something that was welcoming, as I remember him saying. And we also, the team also worked with him on the curb appeal and just being neighborly. And really, when it was done in this really systematic way, from a behavioral perspective, we saw a significant decrease in his physical health symptoms. Again, that decrease in the chronic respiratory issues, a decrease in things like bed bugs, and an increase in being included and socially engaging with neighbors because he lives in a neighborhood. We also have a few folks who have gender identity needs. I know of 2 people who needed support, including finding and attending community support groups so that these participants could learn from, be around, and engage with people who are in their community and maybe struggling with similar things. So we're able to use those community support services to support individuals to find and attend those community support groups. So some of the tradition or typical, if you will, physical health goals and supports that you would see in both of these programs, not just AAW, are around things like medication management. We have a lot of folks that are living independently that struggle to manage their medications. So whether that is a need, some sort of adaptive device to help them remember to take their medications. Again, some individuals have specific health conditions like diabetes, seizure disorders, rehabbing injuries. So we can assist with that through the home and community-based services, as well as Lindsay pointed out, a need for nutritional consultation. We see a lot of that, and exercising and staying active. And certainly, as I mentioned several times, just even the act of managing and attending medical appointments. This is a population who oftentimes has some significant issues around executive functioning and planning the day. So in these programs, determining needs and services is predicated on an assessment protocol that we require at least annually. And I'd like to point out that part of this protocol is a risk identification tool we designed called the Periodic Risk Evaluation, or the PRE. Did that along with Lindsay and some other colleagues, but we're really proud of this tool. It's a quick screening that identifies if the participant presents risks in any areas that we had identified as attributable to risk levels like law enforcement, these chronic medical conditions, unstable living environment. And, this tool paired with other standardized tools gives the team really a roadmap to what needs to be mitigated, where strengths and needs lie, and what services and supports, like the ones that I talked about, would be helpful to addressing these needs. So I'm going to turn it back to Lindsay now. Hopefully that gave you a flavor of the two programs, and with the case examples gave you a sense of some of the things that we're able to do within the programs to address the physical health needs of individuals.
Thank you. I think that was a great way to tack on to that national research and see what this looks like in the backyard, right? Like what's happening in states. So Dr. Nonnemacher and I actually went back and forth a little bit around trying to think about resources, and that's challenging when we think nationally about Medicaid. There is the Centers for Medicare and Medicaid Services, which has the guidelines for all Medicaid programs. The ASSERT Collaborative, which is an initiative funded by the Bureau of Supports for Autism and Special Populations, partnered with the Autistic Self-Advocacy Network to create a self-advocates guide to Medicaid, which contains lots of useful information about how to navigate Medicaid within your own state and locally in the programs and services you may need. And the Administration for Community Living has state-specific protection and advocacy systems in all states that individuals can tune into and ask questions and can help to guide toward ways you can access Medicaid programs. So we have two links for you here in the presentation, and certainly you could also search for those resources if they're helpful as well. So I've got a placeholder here for questions. Maddie, did you want me to show the end slides about future ARP webinars?
Yes, that would be perfect. I know we are at time, and thank you so much, Lindsay and Stacy, for your presentation. I think that if you are willing to stay on for a few extra minutes, maybe you can ask, you can answer the questions that are in the chat, but I want to be respectful of everyone's time. But so yeah, we have a feedback survey, which I will also put in the chat. And then, yes, our social media handles. And if you go to the next slide, we have our webinar for January 18th, which will be in the new year. It's going to be Dr. Brett Nachman. I didn't actually put his name on there, but he is going to be part of that. And I will send the link for that as well.
Okay, and it looks like we had two questions in the Q&A. One was, are the services you mentioned that are covered by Medicaid widely known by individuals who need them? Are there families who may not know what services they have access to with Medicaid? Not sure. Dr. Nonnemacher, if you'd like to take that one, or if I'm happy to address that as you see fit.
Sure. So in Pennsylvania, the services within the programs that we mentioned are known to those folks that become known to our county. We're a county administered program primarily in Pennsylvania. So I think what you're asking here is, so for those individuals who are enrolled with the county, they know what services are available by programs. I'm not sure, Lindsay, if you have something to add to that, but.
Yeah, I think it is hard if the nature of your question, Jeff, is that people need to know about Medicaid programs to enroll in them. So for example, the Adult Community Autism Program, the Adult Autism Waiver, and there are efforts by the state to make sure that there's outreach to a variety of communities. And for example, in Pennsylvania, there's the ASSERT Collaborative, which helps to make lots of information about these programs known all across the state. But I do think there's probably variation in how states handle outreach about programs that individuals can access. In some ways, Jeff, there are initiatives. So for example, certain populations like graduating high school seniors can be targeted for enrollment in Medicaid programs to help make sure they retain access during those critical windows of that transition into adulthood. But there is certainly not a guarantee that all individuals in all places know about all Medicaid services available to them. I think that's a great point and relevant to health outcomes too. And then I think it looks like Dr. Nonnemacher, we had another question around the services that you were walking through, perhaps in Acap or Waiver. Do they include occupational therapy?
So Acap does include occupational therapy, part of the physical health piece of the services in that program. And in the adult autism waiver, when we first started the program, we did include occupational therapy, and it was one of, if not the most underutilized service in the program. I think at the last renewal, we had 0 participants who were using OT. So we did remove that from our service array, but that is part of the state plan as well. So people can access occupational therapy that way.
Thank you. I think we got them all, Maddie.
Yes. All right. Thank you so much again, Lindsay and Stacy, and thank you everybody for attending. Have a great holiday, and we will see you in 2022 with our January webinar. Thanks.
Thanks for having me. Bye-bye.
Bye.